بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه وسلم أجمعين. سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. اللهم علمنا ما ينفعنا وانفعنا بما علمتنا يا كريم. Dear colleagues, this is the last part of the topic imaging of soft tissue tumors. And as you remember, we have finished a lot of topics in this issue, considering the soft tissue, the connective tissue tumors, the fibrohistiocytic tumors, tumors of the fat, tumors of the blood vessels, tumors of the lymphatics, tumors of the muscles, and also the synovial lesions as well as the peripheral nerve tumors. Now we are left with these four parts, which are the diagnosis of extraskeletal, cartilaginous, and osseous tumors, lesions of uncertain or unknown cell origin, the issue of soft tissue metastasis and lymphoma. Then finally, I will provide some of the examples of soft tissue masses that are not tumors. They are of inflammatory nature but can be mistaken for soft tissue neoplasms. Then we'll start by the extraskeletal, cartilaginous, and osseous tumors. Here we have the extraskeletal chondroma, osteochondromatosis, chondrosarcoma, Ewing sarcoma, and myositis ossificans. The extraskeletal chondroma is also known as juxtacortical chondroma or periosteal chondroma, and this is a rare benign tumor which is usually arising from the periosteum of the tubular bones and may represent about 2% of bone tumors, and usually seen in the second and fourth decades of life. The most common sites are the proximal humerus, the distal femur, and the phalanges, tibia, radius, and ulna. Then this is the golden rule that the presence of calcification or ossification in a soft tissue mass should suggest the possibility of an extraskeletal, cartilaginous, or osseous tumor or a tumor-like lesion. This is an example of juxtacortical chondroma. You see some localized irregularity of the cortex of the distal part of the femur, which is one of the common sites for this lesion. By CT, you see a soft tissue mass with some calcific spots inside. By MRI, the mass is of low signal in the T1 and high signal in the T2 weighted image. Of course, this may be mistaken for other lesions like chondrosarcoma, for example, but the appearance and the absence of aggressive findings or aggressive imaging appearance and the age of the patient, this age can also fit for the chondrosarcoma. And then by X-ray and MRI, you will see what's known as suturization of the adjacent cortex. And you see this, which looks like a benign impression on the cortex of the bone associated with sclerotic reaction, which is also an indication of a benign lesion. Then you can see periosteal reaction, and you also see matrix calcification in about 50% of the cases. These lesions are usually intimately related to the cortex of the bone, and they are not usually invading the medullary bone or the soft tissues adjacent to the bone itself. By MRI, you see low signal in the T1 and high signal in the T2. If you inject contrast material, this will show some heterogeneous or maybe marginal enhancement. This is an example of juxtacortical chondroma in the distal part of the tibia. You see the irregularity of the cortex, some of the ossification or soft tissue calcification, and is also evident by CT. By MRI, the mass is of low signal in the T1, high signal in the T2 with marginal post-contrast enhancement. And you should remember that this lesion do not invade the medulla of the adjacent bone and is not usually associated by bone marrow edema or soft tissue edema. Another example of chondroma, juxtacortical chondroma in the distal part of the femur, a common site for this tumor. And you see the irregularity, you see fine matrix calcification as detected by the plain film. In the T1, there is low signal, in the T2, high signal, and marginal post-contrast enhancement, and you do not see any evidence of bone marrow edema in the adjacent bone. Then you see a lesion which is of low signal in the T1, bright signal in the T2 weighted image in a male patient 24 years old, which may suggest the possibility of cortical chondroma or chondrosarcoma. And in most of these cases, biopsy should be taken to reach the final diagnosis. The differential diagnosis of juxtacortical chondroma include periosteal osteosarcoma, chondroblastoma, which occurs in outside the epiphysis. The epiphysis is the most common site, of course, for chondroblastoma. Juxtacortical chondrosarcoma both can have an overlapping features, but usually the chondrosarcoma is more sizable. Cortical desmoid tumor and tenosynovial giant cell tumors, or the tumors of the tendon sheaths, you remember, they are predominantly seen also in the fingers. Then what's known as bizarre parosteal osteochondromatous proliferation, and this is one of the possibilities if the lesions are present in the phalanges. Then extraskeletal chondrosarcoma is also one of the rare types of sarcomas. It represents about 2% of soft tissue sarcoma and 1% of all chondrosarcomas. This chondrosarcoma is considered of high grade than the chondrosarcoma occurring inside the bone. It can affect all age groups, but commonly the age incidence is around 50 years of age. This lesion is also frequently seen in the thigh, which is considered the most common. Less frequent signs such as the head and the neck and meninges and some of the solid organs. The appearance is almost similar to chondrosarcoma anywhere in the body. And these are some of the facts about this particular tumor, which is extraskeletal chondrosarcoma. It may show popcorn calcification, which is considered the clue for cartilage lesion on the plain film or CT. There is variable amounts of matrix calcification. The location of the tumor is in the metaphysis or in the diaphysis or the metadiaphyseal region. 50% occur in the distal femoral metaphysis, especially along the posterior aspect. 29% in the humerus, 8% in the proximal femur, and 8% in the tibia. They are usually round and lobulated juxtacortical masses, as you can see here in the CT and MRI. The size of the tumor ranges from 3 to 17 centimeter with a mean size of 4 centimeter. Codman triangle may be seen due to perosteal reaction. Cortical thickening and cortical erosions can also be seen. Soft tissue mass with calcification. No sun ray speculations, and T2 high signal intensity, and this tumor is associated with edema, either intramuscular edema or the tumor extension into the adjacent muscle or irregular soft tissue margin of the tumor. These are the incidences for the involvement of the adjacent muscles. And this is a lesion which is adjacent to the cortex. and you see the matrix calcification and the bright signal in the T2 weighted image. This can also fit for parosteal chondroma. As you can see here, chondroma may have the same imaging characteristics. However, there are always much smaller. Then you may remember that chondroma and chondrosarcoma juxtacortical may have similar criteria on imaging, but the size is large if the possibility is chondrosarcoma. And this is another example of parosteal chondrosarcoma. You see the osteolytic lesion or the bone rarefaction in the proximal humerus. The lesion is of low signal in the T1, high signal in the T2 with marginal post-contrast enhancement and the edematous changes surrounding the lesion. And this is another example for a tumor arising from or adjacent to the cortex of the rib. You see the soft tissue mass with matrix calcification. And this is the difference between parosteal or periosteal chondroma and periosteal chondrosarcoma. And you see here that the tumor is relatively more sizable in chondrosarcoma. It involves a good part of the cortical thickness in chondrosarcoma, and there may be some perosteal reaction in both conditions. Then this is in extraskeletal chondrosarcoma, and these are the differential diagnoses. Other sarcomas like synovial sarcoma, malignant fibrous histiocytoma, and of course fibrosarcoma, extraskeletal osteosarcoma, and some of the benign lesions like myositis ossificans. Ewing sarcoma can also occur extraskeletal, and this is a rare tumor, and the age incidence between 20 months and 30 years of age. This is a rapidly growing solitary superficial or deep soft tissue mass, and the mass size may range from 5 to 10 centimeter at the initial presentation. These are the common locations: paravertebral, lower limb, chest wall, pelvis, and the hip. Then the extraskeletal Ewing sarcoma is an aggressive lesion with a high rate of local recurrence, reaching about 30%, and also a high rate of distant metastasis. Then if you look here, and you can see that the imaging findings are non-specific. You can see a big mass in the back or the lateral aspect of the lower thigh, and the mass is of low signal in the T1, high signal in the T2, heterogeneous post-contrast enhancement, and this may simulate any other sarcoma like the synovial sarcoma, for example, the rhabdomyosarcoma, and also soft tissue metastasis and lymphoma can also produce similar findings. And the T1, the tumor is of low signal, in the T2 is of high signal, may show some fluid levels, and may show a pseudocapsule with high flow vascular channels. This is one of the hypervascular lesions. And if you inject the contrast material, there is homogeneous heterogeneous enhancement, and in the bony scan or the PET scanning, you can see significant radionuclide uptake. This is the extraskeletal Ewing sarcoma. You see the plain film shows a soft tissue tumefaction with no involvement of the adjacent bone. And in the coronal T1, the tumor is low signal, T2 and STIR heterogeneous high signal and heterogeneous post-contrast enhancement. This is also the same case, but you see the lateral X-ray showing the mass in the back of the knee, and is low signal in the T1, high signal in the T2, and the heterogeneous post-contrast enhancement. The differential diagnosis of extraskeletal Ewing sarcoma include lymphoma, rhabdomyosarcoma. Sometimes some of the infectious lesions and abscesses may show similar findings. Then we came to the myositis ossificans, which is also one of uncertain origins, and this is a benign lesion resulting in heterotopic ossification, usually in the large muscles. And this lesion is known in the literature as don't touch lesion. And you know that the most common cause of myositis ossificans in adults is the trauma, and if you try to surgically remove this, you initiate another trauma which will participate for another lesion. And this is known as myositis ossificans circumscripta, which is usually the second the sequelae of trauma. But there is a rare type of myositis ossificans, which is known as myositis ossificans progressiva, and this is inherited disorder characterized by fibrosis and ossification of the muscles and tendons and the ligaments. There is also another type of myositis ossificans known as panniculitis ossificans occurring in the subcutaneous tissues, and a fourth type, which is a pseudotumor of the digit, which is a variant of myositis ossificans. Then what you can see by the plain X-ray, CT, and MRI is a big mass of irregular appearance, usually near the site of a traumatized area. And here you can see this is the prosthesis for a radial head after maybe a radial head fracture, and the radial head has been removed and replaced by this metallic prosthesis, and you got some myositis ossificans in the muscles around the elbow. And here, another case of total knee replacement participated for the development of this big mass of bone along the anterior aspect of the lower femur. Then there is circumferential calcification with lucent center. This is usually seen by CT more better. Also, a radiolucent cleft, which is known as the string sign. There is a radiolucency, linear radiolucency separating the bony mass from the cortex of the adjacent bone. Then this is known as the string sign, which is one of the criteria of myositis ossificans. Calcification appear on the plain film 2 to 6 weeks after the insult, and the lesion reaches the classic appearance by 2 months. Then over the following 4 months, the lesion becomes smaller and more dense. And if you try to diagnose myositis ossificans by MRI, I think that you will do a big mistake, since you will imagine this tumor as one of the sarcomas, for example, and also if you inject this lesion by contrast, it will enhance. If you have a PET CT, it will show metabolic activity. Then the best way to deal with myositis ossificans, if clinically suspected, is to have plain film or CT scan. Then these two imaging modalities can be followed after that by MRI. But if the initial investigative tool is MRI, you may do some mistakes. Then this lesion will appear in the T1 isodense to the muscle, as you can see here. And the T2 weighted image, there is peripheral edema, high signal, and you may see also a high heterogeneous signal in the tumor itself. If you inject contrast material, the lesion will enhance. Then it is easy to diagnose this by CT as heterotopic calcification or ossification within the muscle. This is a female patient, 83 years old, with 1 week history of palpable mass in the thigh. There was no history of trauma. And if you see the lesion is of low signal in the T1, high signal in the T2, significant post-contrast enhancement, and also bone scintigraphy, which is not shown here, showed dense uptake in the lesion. The mass was suspected to be one of the soft tissue sarcomas, and the CT showed dense calcification. Biopsy confirmed the diagnosis of myositis ossificans. Then this is the case I have shown before. You see a mass after bony mass after the total knee replacement. The mass is evident being made of bone and the CT scan, but in the MRI you see low signal in the T1, high signal in the T2, which can be easily mistaken for a neoplasm. And the CT scan you see peripheral enhancement with central radiolucency, and in this MRI post contrast image you see significant enhancement of the lesion. Then we have four lesions of uncertain differentiation. The exact cell of origin is actually unknown. And you remember, I have mentioned before the synovial sarcoma, and also I have mentioned the rhabdomyosarcoma. And now we will say something about tumoral calcinosis, intramuscular myxoma, and the alveolar soft part sarcoma, which is one of the rare sarcomas, but well known in the literature and in the clinical practice. Tumoral calcinosis is a rare familial condition characterized by painless, periarticular calcified mass. This is the deposition of calcium is caused by hereditary metabolic dysfunction of the phosphate regulations. Then you got a big mass adjacent to the bone or adjacent to the joint, and this mass is usually painless. Sometimes may cause pain and tenderness if there is compression of one of the vital structures, and very importantly that the adjacent bones looks normal. There is no bone erosion, no periosteal reaction, no destruction, and so on. Then the common locations are the hip, the shoulder, the elbow, the foot, and the wrist. And this is an example of tumoral calcinosis. See what's known as cloud-like calcification or ossification adjacent to the joint. And if you look carefully, you see that the bones are intact with no erosion, no destruction, and no periosteal reaction. Sometimes these lesions may, on MRI, may show fluid levels due to what is known as milk of calcium fluid levels. In the T1, they are inhomogeneous of low signal intensity, of course, and in the T2, they show heterogeneous signal intensity with foci of calcification or ossification showing low signal. And the differential diagnosis is very long, including, of course, myositis ossificans, calcinosis circumscripta, calcinosis universalis, milk alkali syndrome, hypervitaminosis D, calcinosis of chronic renal failure, calcific tendinitis, synovial osteochondromatosis, synovial sarcoma, osteosarcoma, calcific myonecrosis, gout, hyperparathyroidism, the brown tumor, calcium pyrophosphate deposition disease, also which is known as pseudo-gout. These are the differential diagnosis of this lesion. And here you see in a female patient, 50 years old, bilateral upper thigh, very big masses of dense calcification, and the femora are intact. Another example, you see a bilateral big masses around the hip joint showing dense calcification and ossification, and there also you can see this fibroid in the uterus. And this is by CT and MRI. CT axial and coronal, MRI T2 weighted image, and CT 3D reconstructed image of tumoral calcinosis, and you can see what is known as multiple fluid levels within the lesion in the T2 weighted image. Another example of tumoral calcinosis bilateral affecting a common location of this lesion, and also you may see on T2 weighted image what is known as the fluid levels. The next is the intramuscular myxoma, which is a rare type of soft tissue myxoma. The incidence is 1 per million and frequently diagnosed in females around in and about 55% of cases around the 55 years of age. The presentation is by a slowly enlarging mass, and the mass will range between 1 centimeter and 17 centimeter. Multiple myxomas associated with fibrous dysplasia is known as Mazur-Broad syndrome, and intramuscular myxoma can be located in any of the skeletal muscles, commonly the quadriceps, the hip adductors, the gluteus muscles, and the upper arm. Then by ultrasound, and you got this hypoechoic mass with minimal or little vascularity around the tumor. In about 85% of the cases, there is a bright rim surrounding the tumor from one of its poles. And here you may see that there is a bright rim, which is known as the bright rim sign around the tumor. This is not, of course, a significant sign, but it's just a finding. The bright cap sign is a triangular hyperechoic area adjacent to at least one of the poles of the lesion. And the lesion is hypovascular or even avascular, but if you have the PET scan, it will show significant metabolic activity. And this is an example by ultrasound MRI T1 MRI with contrast. They see a homogeneous hypodense lesion. The density is usually higher than water but less than the surrounding muscles. There is maybe mild diffuse or peripheral enhancement. The pseudocapsule or perilesional rim of fat or edema may be present. T1 hypointense, T2 hyperintense, T1 post-contrast variable enhancement. And this is an example of intramuscular myxoma, which may simulate any of the previously mentioned sarcomas during the whole course of these soft tissue masses. You can see a low signal intensity in the T1, bright signal in the T2, heterogeneous post-contrast, and of course, biopsy is the definitive procedure to reach the final diagnosis, which was an intramuscular myxoma. Differential diagnosis of this myxoma will include peripheral nerve sheath tumors like schwannoma and neurofibroma, myxofibrosarcoma, lymphangioma, chronic intramuscular hematoma. Of course, the chronic hematoma will be of black signal in most pulse sequences, myxoid liposarcoma, myxoid fibrous histiocytoma, extraskeletal chondrosarcoma, and botryoid rhabdomyosarcoma. Then we came to the last one in this group, which is the alveolar soft part sarcoma, and this is the rare, highly vascular lesion. The incidence is less than 1% of the soft tissue sarcomas, and the cell of origin is unknown. The tumor derives its name from the fact that histologically the tumor cells will arrange or are arranged in the same pattern as the alveoli. Then, hence, it's called alveolar soft part sarcoma. It is one of the rare sarcomas that occur anywhere in the body, but commonly they affect the head and the neck, especially in infant and children. They can give metastasis at the time of the diagnosis to the lung, the bone, and the brain. And if you look to the tumor, is similar to any other sarcoma, but one of the characteristic findings is the hypervascularity. And you can see extensive signal void vessels around the periphery and even in the tumor itself. The tumor CT angiography will show hypervascularity. It's hyperintense on the T2 weighted image with multiple signal void vessels. If you inject the contrast, it will show heterogeneous or homogeneous enhancement. and this is the T2, and this is post-contrast. You see extensive vascularity around the tumor. And this lesion may be differentiated from malignant fibrous histiocytoma, synovial sarcoma, angiosarcoma, osteosarcoma, and sometimes the vascular malformation. And this is an example of alveolar soft part sarcoma in the shoulder, showing an extensive enhancement after contrast injection in the CT and also in MRI, T1, FAT-SAT, post-contrast. And you see the signal void vessels, you see the marked vascularity on CT angiography of this particular tumor. Another example of alveolar soft part sarcoma, they see the tumor in the T2 weighted image, the tumor after contrast injection, and you can see extensive vascularity along the periphery of the lesion. Then we came to the last issue of soft tissue metastasis and soft tissue lymphoma. And soft tissue metastases are uncommon, and we can diagnose this by the presence of the primary malignancy. Sometimes you see this example, there is a bronchogenic carcinoma and a subcutaneous deposit in the anterior chest wall. The most common primaries give soft tissue metastases are the lung, the melanoma, the kidney, and the colon. Then the radiographic signs are not specific. Calcium can be seen in pancreatic and gastric deposits as well as also in osteosarcoma. And then the diagnosis is somewhat easy if you know that the patient had a primary malignancy. Then if you see a mass in the chest wall and on Doppler study, you can see extensive hypervascularity and the patient is known to have a breast carcinoma, then you know that this is metastatic deposit. Ultrasound will show hypoechoic hypervascular mass. MRI has no signal characteristics, low T1, high T2, and variable enhancement. And PET scan will show the primary tumor, which may help in the differential diagnosis. And here you can see this is an example of a subcutaneous metastatic deposit in a patient with phylloid breast cancer. And this patient with renal cell carcinoma, they see by ultrasound a big mass in the posterior aspect of the thigh. After contrast enhanced MRI, you see heterogeneous enhancement. This is similar to any of the malignant lesions that have been mentioned before. But because of the presence of a known primary malignancy, you should think of this possibility of soft tissue metastasis. This patient with lung cancer has a mass in the gluteus muscles, and on PET-CT there is significant metabolic activity, and this was metastatic deposit. And this patient with melanoma has a mass in the groin on the left side. The mass showed heterogeneous post-contrast enhancement, heterogeneous low signal in the T1, high signal and the T2 weighted image, and heterogeneous post-contrast enhancement in this T1 FAT-SAT image. Then we came to the soft tissue lymphoma, and lymphoma can involve any part of the musculoskeletal system. And muscle lymphoma is rare, representing less than 2% of all lymphomas. But the incidence of lymphoma has increased, especially corresponding to the increase in the immunocompromised patients. Most of the muscle lymphomas are of the non-Hodgkin type, and the age of presentation is around 70 years of age. Any muscle can be involved, but commonly the thigh, trunk, and upper limb, and also the leg. Metastatic spread from primary nodal or osseous disease are common than the primary type of muscle lymphoma. Then, if you look here, and this is low signal in the T1, significant post-contrast enhancement, and high signal in the T2 weighted image, this patient had the right thigh mass of 2 of 2 months duration, and she is 70 years old. The patient had a previous history of non-Hodgkin lymphoma of the breast 26 years ago. Then, because of the known history of lymphoma, you may suspect that this is also lymphoma. Then, big mass in the back of the thigh, low signal in the T1, high signal in the T2, and homogeneous post-contrast enhancement. Another case of pathologically proved soft tissue lymphoma of the gluteal muscles, a large mass of low signal in the T1, high signal in the T2, and the heterogeneous post-contrast enhancement. And the differential diagnosis of soft tissue lymphoma will include, of course, soft tissue metastasis, rhabdomyosarcoma, extraskeletal Ewing sarcoma, any other type of the sarcomas, and may also infectious myositis. Then finally, we came to the what's known as the pseudo tumors. This, these, this is a group of lesions that may simulate sometimes the soft tissue tumors, and they are mostly of inflammatory nature. I will show some examples of these lesions, starting by cellulitis, and this is an acute infection of the skin and the subcutaneous tissue, and cellulitis, of course, is not transmitted from person to person by contact. Diabetic patients with peripheral vascular disease are more susceptible to this type of infection. By ultrasound, there is echogenicity and increased thickness of the skin, haziness, and increased echogenicity of the subcutaneous fat. And cellulitis is one of the straightforward clinical diagnoses, and most of the cases it needs no imaging, but imaging is usually resorted to for fear of complications. The complications of cellulitis will include extension into the deep soft tissues, formation of abscesses, development of infectious myositis, necrotizing fasciitis, extension to the bone forming osteomyelitis, and extension to the vessels forming thrombosis and thrombophlebitis. This is an easy diagnosis of cellulitis in the anterior part of the pubic symphysis. Then you can see the heterogeneous soft tissue density in the fat with relative skin thickening and stranding of the surrounding fat. Then necrotizing fasciitis, this is the rapidly progressive fatal infection, and the mortality rate may reach as high up 70%, 75% of the cases. It affects the skin and the deep soft tissues and may reach also to the muscles. It's very common in immune compromised patients, especially those with HIV infection, diabetic patients, cancer patients receiving chemotherapy, alcoholic patients, and patients with organ transplant, of course, due to the immunosuppressive uh, therapy. This lesion can also be diagnosed after trauma or even around retained foreign bodies. There are two or well recognized forms: the polymicrobial infection, which is most common, or the single organism infection, which is caused by the group A streptococci, which is known as the flesh-eating bacteria. Then treatment is urgent by surgical fasciotomy and the debridement of the necrotic tissue. The plain film will show, sometimes it will show areas of gas shadows extending deep into the soft tissues. But many times this is a late appearance of necrotizing fasciitis. There is, of course, maybe very edematous soft tissue swelling seen by the plain film, but the CT and MRI will show the extensive intramuscular gas shadows, which also seen in the subcutaneous area and can extend into the deep soft tissues. The lesion may be associated with vascular damage leading to intramuscular hemorrhage, and there is asymmetrical facial thickening with, of course, a stranding of the fat, as you can see here, muscle and intermuscular septal edema, diffuse facial fluid collections, usually due to abscesses. And this is an example of necrotizing fasciitis in the gluteal region, extending deep into the pelvic floor, affecting the ischiorictal fossa. And abscesses may also be mistaken for soft tissue masses, but they have the characteristic clinical findings and also the characteristic imaging findings. The imaging findings are those of a hypodense lesion with well-defined marginal enhancement of regular thickening, sometimes edematous changes in the surrounding fat and mass effect on the adjacent structures. Abscesses are classically appear like this. They can be single, can be multiple, and they can be caused by a variety of organisms. The infectious myositis is the inflammation of the skeletal muscles by bacteria seen in young adults, and these are the risk factors: the HIV, muscle edema, cellulitis, insect bites, injection of these drugs, and diabetes. And the most commonly encountered organism is the Staphylococcal aureus, which is seen in about 75% of the cases. A spread of this infection may reach the bone, resulting in osteomyelitis, and may reach the joint, resulting in septic arthritis. And this is an example of infectious myositis with multiple abscesses, marginally enhancing abscesses throughout the thigh muscles in this diabetic patient. And this is infectious myositis affecting the skin and the subcutaneous fat with significant swelling and high signal in the T2 weighted image. If you inject contrast material, the lesion may enhance. If there are buckets with marginal enhancement, this indicates abscesses, but in this particular case, you do not see abscesses, you see only swelling of the muscle, which is of low signal in the T1, high signal in the T2, and the heterogeneous enhancement after contrast injection. And this is also an example of infectious myositis with localized abscess formation and the medial aspect of the upper thigh, showing low signal in the T1, high signal in the T2, and marginal post-contrast enhancement. These are the suspected imaging findings in cases of infectious myositis, including diffuse muscle swelling, stranding of the subcutaneous fat, marginally enhancing abscesses, obliteration of the intermuscular fat, extension to the bone, vascular thrombosis, artery or vein, and compartment syndrome. Lymphedema is also one of the lesions that may cause diffuse swelling of one or both limbs, and there are two main types: the primary lymphedema and the secondary one. The secondary lymphedema is usually the sequelae of surgery, like removal of the regional lymph nodes, as in cases of breast cancer, radiation, metastasis to the lymph nodes, and infection, which will impede the lymphatic drainage, leading to accumulation of the lymph in the vessels, resulting in this progressive swelling of the foot. Congenital lymphedema is seen in the newborns, and lymphedema barox is present before the age of 35 years, and lymphedema tarda is present after the age of 35 years. Lymphedema is very common in females, and the age of presentation is around 11 to 17 years. There are four stages of lymphedema, starting by mild edematous changes in the dorsum of the foot, then involvement of the leg, then the development of small creases, and after that the elephantiasis or the development of diffuse limb swelling with multiple creases. And this is lymphedema after chemo and radiotherapy for breast cancer. There is significant upper limb swelling with stranding and reticulation of the subcutaneous fat. And this is lymphedema of the thigh and the calf secondary to vascular occlusion. And you can compare the affected thigh by the normal thigh with a marked increase in the thickness of the subcutaneous fat, which is totally involved by fluid and inflammatory densities. Hydrated cyst in the soft tissues is considered very rare, and it may be seen anywhere in the body, but commonly in the thigh. These are the muscles affected by the hydrated disease, like the sartorius, the quadriceps, and the gluteal muscles. Hydrated disease in the muscle is usually secondary to hydrated disease present elsewhere in the body. And the hydrated disease anywhere will show the classic appearance of a cyst with calcification, or a cyst with floating shadows, or a cyst with multiple daughter cysts inside. This is considered one of the best diagnostic signs of hydrated disease. And this is hydrated disease of the thigh of a female patient 85 years old, showing the classic appearance of an extensive hydrated disease of the thigh. The cat scratch disease is a regional lymphadenitis secondary to infection by this organism due to cat scratch. And the lymphadenopathy is usually seen in the elbow, and sometimes the axilla may be affected, and the cervical lymph nodes may be also affected. But what's important for us here is the presence of lymphadenitis of the epitrochlear lymph nodes near the elbow, which will form a soft tissue mass that can be mistaken for a soft tissue tumor. This is a well-known site for cat scratch disease and commonly seen in those who are dealing with animals and cats in particular. And you see a low signal mass in the T1, high in the T2, and significant enhancement after contrast. And the inflammatory nodes usually show some vascularity on imaging. Then foreign body granuloma, which is also one of the lesions that can be mistaken for soft tissue sarcomas. You can read this statement. Foreign body granuloma can be misdiagnosed as soft tissue tumor if the foreign body is not seen. And this is one of the important issues, is to detect the foreign body by imaging, either by ultrasound, by CT, or by MRI. And here in this X-ray, you see this foreign body radio opaque in the distal part of the Achilles tendon, and by ultrasound you see the foreign body with acoustic shadowing, and you see a soft tissue mass around this foreign body, which is an indication of foreign body granuloma. Finally, we came to the calcific myonecrosis, which is a rare post-traumatic complication characterized by latent formation of dystrophic calcified mass in the affected muscle. And the literature, according to the literature, this lesion is almost totally confined to the leg muscles. And you may see a big mass in the affected muscle containing amorphous calcification, and there may be some erosions of the adjacent bone and also periosteal reaction. CT is the best way to detect this calcification and to see the lesion. Fluid calcium levels and reactive periostitis can be also seen. And the T1, the lesion is of intermediate signal, and the T2 is high signal. And if you inject contrast, this lesion will not enhance. Sometimes you see calcium by gradient echoes, and the STIR image will show the perosteal reaction and the high signal intensity of the lesion. Then this is, according to the literature, uh, almost the typical location of calcific myonecrosis, where you can see this heterogeneous appearance of calcium in the leg. And this is by CT and by MRI. You see that the muscle in the anterior group of the thigh is affected by this hypodense mass with peripheral calcification, and this is the appearance of the mass in the T2 weighted image. Ultrasound and uh, and MRI of a muscle hematoma. Sometimes the patient is traumatized, he develops hematoma that is frequently neglected. Then imaging at any time will show a mass within the muscle, which may not show the typical appearance of blood. Then it may be mistaken for a tumor, and this is a subacute hematoma in the muscle. This is T1 showing some bright signal of subacute blood, and this is the stir image, and this is T1 post contrast. The lesion will not enhance with contrast. Finally, we have uh, discussed the issue of soft tissue tumors, and we classified the tumors into 12 groups. Then, this is to sum up what we have said during the 4 parts of these lectures. And in order to diagnose or to reach the differential diagnosis of a soft tissue tumor, you may depend on the anatomic location, the MRI signal, and other characteristic MRI appearances. Then what about the location? Lesions diagnosed by location, which have characteristic location like nuchal fibroma in the back of the neck, elastofibroma in the chest wall, palmar fibromatosis in the hand, plantar fibromatosis in the foot, desmoid tumor in the anterior abdominal wall, densoma in the Achilles tendon, tendon sheath lipoma along the tendon sheath of any tendon, parosteal lipoma along the adjacent cortex of the bone with characteristic parosteal new formation, the glomus tumor underneath the nail, ganglion cyst adjacent to the joint, Baker cyst in the back of the knee, olecranium bursa posterior to the olecranium, prepatellar bursa anterior to the patella, cat scratch disease, epitrochlear lymph nodes, calcific myonecrosis in the leg. And intra-articular lesions are the pigmented velonodular synovitis with characteristic MR appearance, lipoma arborescens, synovial hemangioma, and synovial osteochondromatosis. Then by the signal intensity, lesions with high signal in the T1, lipoma, lipoblastoma, lipoma of the tendon sheath, parosteal lipoma, hibernoma, and low-grade or well-differentiated liposarcoma. Then low signal in the T2 weighted image are characteristic of nodular fasciitis, palmar fibromatosis, plantar fibromatosis, tenosynovial giant cell tumors, including the pigmented velonodular synovitis and giant cell tumor of the tendon sheath, as well as the xanthoma of the Achilles tendon. Lesions which do not enhance after injection of contrast both in the CT and MRI include lipoma, lipoblastoma, ganglion cyst, Baker cyst, hydatid cyst, and lymphangioma. Then calcium is present in the hemangioma, calcific philippoli, Mahfouz syndrome, calcific philippoli also, parosteal chondrosarcoma, parosteal chondroma, myositis ossificans, tumor calcinosis, synovial sarcoma, calcium is very important here, rhabdomyosarcoma, lipoma, liposarcoma, and angioleiomyoma. Then posterior acoustic enhancement by ultrasound is seen in cystic lesions like ganglion cyst, Baker cyst, lymphangioma, schwannoma, intramuscular myxoma, and sebaceous cyst. Diffuse lesions include lipomatosis, lymphangiomatosis, lymphedema, and Klippel-Trenaunay syndrome. Then lesions that are hypervascular, hypernoma, vascular malformation, angiosarcoma, Klippel-Trenaunay syndrome, alveolar soft part sarcoma. Lesions with diagnostic signs, bowl of grapes in liposarcoma, all these signs I have mentioned before, a split fat sign in neurofibroma, target sign in neurofibroma, fascicular sign in schwannoma, sedimentation sign in tumoral calcinosis, bright cap sign in myxoma, intramuscular myxoma, water lily sign in hydatid cyst, known primary malignancy in soft tissue metastasis, known lymphoma in soft tissue lymphoma. Then lesions which are characteristic of male or female or child. Elastofibroma is particularly seen in females, desmoid tumors in females, ganglion cysts in females, lipoblastoma, a child, rhabdomyosarcoma, a child, infantile fibrosarcoma in infant. Then lesions with non-specific imaging findings at all. Intra-abdominal desmoid, extra-abdominal desmoid, solitary fibrous tumor, benign fibrous histiocytoma, malignant fibrous histiocytoma, fibrosarcoma, leiomyosarcoma, synovial sarcoma, extraskeletal Ewing sarcoma, alveolar soft tissue part sarcoma, malignant peripheral nerve sheath tumor. Thank you very much. Alhamdulillah Rabbil Alameen.